So I'll be talking about acute kidney injury. The goals for the next half hour are as follows. I'd like to introduce you to some of the new terminology of acute renal failure, which has now been renamed acute kidney injury, talk about the most recent consensus definition of acute kidney injury. Then I'll introduce the incidence, mortality, and the excess costs that are associated with acute kidney injury, or AKI, provide you a general approach to the patient with acute kidney injury, and then go over some specific clinical scenarios that you've probably seen in your practice and that you may see on the board exam or recertification exam. Let me begin with a case just to frame our discussion, and we'll be returning to this case over the course of the next few slides. This was a 64-year-old man with hypertension, diabetes, osteoarthritis, and BPH. He presented to the emergency department complaining of nausea and vomiting. His medications included lisinopril 40 milligrams a day, metformin 1 gram BID, and ibuprofen 800 milligrams TID. On exam, his blood pressure was 100/60, heart rate 104, respiration 16. His lungs were clear. The cardiovascular exam showed a regular rate and rhythm with a normal S1 and S2. There was no pericardial friction rub and no jugular venous distension. His abdomen was soft, and his extremities showed no edema. His laboratory evaluation revealed a sodium of 134, potassium 5.6, chloride 100, bicarbonate 18, BUN 84, and a serum creatinine of 3.2. So we'll use that case and refer back to it as we move along. So when I started internal medicine training, it was called acute renal failure. It's now been renamed to acute kidney injury. And that was about 8 years ago now. A consensus group, the Acute Dialysis Quality Initiative, got together and decided for a variety of reasons to rebrand acute renal failure, to call it acute kidney injury. So acute, of course, refers to the fact that the condition occurs within hours to days. The term kidney replaces renal just because it's a little bit more familiar to the general public. Probably the most important change in the definition was the introduction of the term injury as opposed to failure. And the reason for this is not all cases of acute renal failure were actually failure. And the term injury, or acute kidney injury, refers to the presence of organ damage. So that's been a major shift in terms of the paradigm with which we approach acute kidney injury, acute renal failure. The definition of acute kidney injury has bedeviled us for some time. There's been over 30 definitions in the literature, ranging from mild increases of 0.3 milligrams per deciliter to stratified definitions based on the baseline serum creatinine, to percentage increases, like a 50% increase within 40 hours. So over 30 definitions if you look throughout the nephrology literature in the last 20 years. In response to that, in order to facilitate epidemiologic studies, interventional trials, and to improve, hopefully, clinical care, a number of groups have come together to introduce a consensus definition. There have been two consensus definitions. The Acute Dialysis Quality Initiative came up with the RIFLE criteria, and then the Acute Kidney Injury Network came up with the AKIN criteria, and more recently, a third group has gotten together called the KDIGO group, and this is Kidney Disease Improving Global Outcomes. And I show you the definition here. They've defined acute kidney injury as an increase in serum creatinine of greater than or equal to 0.3 milligrams per deciliter in a 48-hour period, or a 1.5-fold increase in serum creatinine in 7 days, or the presence of oliguria. So this is also controversial and a new introduction into the definition over the last few years. Just the presence of oliguria itself has been taken to denote acute kidney injury. Acute kidney injury can be deadly. This was a study by Dr. Glenn Chertow, who was at Brigham and Women's Hospital in 2005. Plotted here on the y-axis are the odds of death, and on the x-axis, various increases in serum creatinine. So as you can see, patients who had a large increase in serum creatinine of 2 milligrams per deciliter during their hospitalization had markedly increased risks of death. On the y-axis here is the odds of death. So this is an 80-fold increased risk of death compared to patients without acute kidney injury. And the various bars refer to varying levels of multivariable adjustment. So in a fully adjusted model, a large increase in serum creatinine of 2 was associated with over a 50-fold increased risk of death. What's interesting, I think, about this study is that even when the injury or the change in serum creatinine was small, 0.3 to 0.4 milligrams per deciliter, there was a 70% increased odds of death. That led a lot of the consensus groups that were formulating new definitions to really focus on these smaller changes in serum creatinine because they were so prognostically significant. Acute kidney injury is becoming more and more common over time. About 5 to 7% of hospital admissions are complicated by acute kidney injury, up to 50% of ICU patients. We studied the epidemiology of acute kidney injury using a nationally representative database and examined the years 1988 through 2002. And over that 15-year period, we found that there was a 4-fold increase in the risk of acute kidney injury and a 6-fold increase in the incidence of acute kidney injury requiring dialysis. Dr. Chi Shu published about 5 years ago now a study out of Northern California looking at the rising incidence of acute kidney injury and found that the incidence rose from 322 per 100,000 patient years in 1996 up to 522 per 100,000 patient years in 2002 to 2003. So this incidence of 522 per 100,000 is comparable to the risk of stroke in other estimates. The development of acute kidney injury is extraordinarily expensive. There's a 60% increase in costs associated with the care of patients following cardiac surgery when you define acute kidney injury as a 50% rise in serum creatinine. An additional $5,000 when serum creatinine increases by just as little as 0.3 milligrams per deciliter. And it's been estimated that annually there's an excess of $10 billion spent on the care of patients who develop acute kidney injury. So let me move away from the epidemiology and talk to you about the approach to the patient with acute kidney injury. This is just an overview of the anatomy. You see the kidneys draining to the ureters and then into the bladder. This is the microanatomy of the kidney, the glomerulus, where the filtrate is formed, and then the tubules, and then the collecting duct. And we'll be going back to this these slides when we talk about the differential diagnosis of acute kidney injury. So when we approach the patient with acute kidney injury, it's been traditional to divide it into 3 broad categories, and I think this is a very useful framework. We think about pre-renal azotemia, intrinsic renal causes, and post-renal failure. So post-renal failure can occur whenever there's an impediment to the flow of urine anywhere along the urinary tract. So proximally, close to the kidney or in the ureters, stones or blood clots, external compression, tumor, or retroperitoneal fibrosis. Within the bladder itself, the bladder and prostatic enlargement can impede urinary flow, blood clots within the bladder, tumors, strictures within the urethra, and of course the obstructed Foley catheter, all causes of acute kidney injury, post-renal acute kidney injury. In terms of the approach to the patient suspected of having acute kidney injury, the steps are to check a bladder scan, insert a Foley catheter, and then imaging, so a renal sonogram, ultrasound, or a CT. One pearl to keep in mind is that you may have a false negative ultrasound. There may be no hydronephrosis on ultrasound early in the course of obstruction or in the setting of retroperitoneal fibrosis or tumor where the kidneys and ureters are encased and are not allowed to increase in size. For these patients in whom obstruction is still on the differential diagnosis, a retrograde pyelogram may sometimes make the diagnosis. So that's post-renal. So pre-renal azotemia occurs when serum creatinine increases due to renal hypoperfusion. There's thought to be no structural injury to the kidney, and there's generally prompt recovery of glomerular filtration rate when the hemodynamics are restored. Hypovolemia is the major cause of pre-renal azotemia, but any cause of renal hypoperfusion can lead to a rise in serum creatinine, for example, a decrease in the cardiac output, a decrease in the effective circulating volume, for example, in the settings of congestive heart failure or cirrhosis, and then impaired renal hemodynamics with NSAIDs, ACE inhibitors, and angiotensin receptor blockers. So when there's hypovolemia, the kidney has several compensatory mechanisms to deal with the reduction in blood flow. First, there's increase in vasodilatory prostaglandins that causes dilation of the afferent arteriole, so this increases blood flow into the glomerulus. There's also increase in angiotensin II levels locally, which cause vasoconstriction of the efferent arteriole, which increases the pressure here in the glomerulus. And those compensatory mechanisms serve to maintain GFR at a normal range in response to hypoperfusion. Now, when that fails, it can fail because those compensatory responses are overwhelmed, or in the setting of NSAIDs. So remember, NSAIDs act here on the afferent arteriole. By inhibiting vasodilatory prostaglandins, they can lead to pre-renal azotemia. ACE inhibitors and angiotensin receptor blockers act here. They block angiotensin II, mediated vasoconstriction of the efferent arteriole. And keep in mind that all NSAIDs, including COX-2 inhibitors, and both ACE inhibitors and angiotensin receptor blockers can lead to pre-renal azotemia. Intrinsic acute kidney injury is more of a mixed bag. And I think the best approach in terms of considering the causes of intrinsic acute kidney injury is to break up the kidney into the various anatomical parts. So there are the small vessels. Here's the glomerulus here, and the small vessels that are leading to the glomerulus, the afferent arteriole. There are the larger vessels in the kidney. There are the tubules, where the filtrate is processed, and this is a cross-section of the tubules. And then there's the interstitium, the important part of the kidney in between the tubules. So in terms of a differential diagnosis of causes of intrinsic acute kidney injury, in the small vessels there may be glomerulonephritis, vasculitis, TTP-HUS, disseminated intravascular coagulation, atherembolic disease, severe hypertensive crises, and sepsis. In the larger vessels, there may be an embolus or dissection, vasculitis, renal vein thrombosis, and the abdominal compartment syndrome. Tubular injury is one of the dominant causes of acute kidney injury in hospitalized patients. Ischemic acute tubular necrosis from hypotension. Sepsis can cause tubular injury. And there are also some endogenous toxins to keep in mind. So in the setting of rhabdomyolysis or hemolysis, there may be pigment injury to the tubules. And then exogenous toxins that we administer to patients that can be toxic to the tubules include contrast agents, cisplatin, and gentamicin. You can also have intratubular obstruction. So for example, in the setting of myeloma proteins can aggregate here and block the tubules and lead to an increase in the pressure within the glomerulus, which impedes filtration. There may be uric acid crystallization in the setting of tumor lysis syndrome, or just tubular cells that have clogged up the intratubular space. And then certain drugs, acyclovir and methotrexate, can also precipitate within the tubules. The interstitium is another important anatomic compartment for acute kidney injury. There may be allergic interstitial nephritis, for example, with penicillin or rifampin. Certain infections can also cause interstitial inflammation. So severe pyelonephritis can cause acute kidney injury if very severe. Legionella, and then sepsis itself is thought to cause interstitial inflammation. There may be infiltration of tumor cells into the interstitial space in the setting of lymphoma or leukemia. And then certain inflammatory diseases, Sjogren's, sepsis, tubular interstitial nephritis with uveitis can cause acute kidney injury because of inflammation in the interstitium. So that's the anatomical approach. The clinical approach, in terms of the causes of acute kidney injury, I like to divide up into the clinical setting, so outpatient, inpatient, and international. So the dominant causes of acute kidney injury in the outpatient setting are pre-renal azotemia and obstruction. In terms of pre-renal azotemia, keep in mind that patients who are on ACE inhibitors, and if they're having hypovolemia from diarrhea or vomiting, it's a very nice setup for pre-renal azotemia, as is the concomitant use of ACE inhibitors and NSAIDs, a very common setting in which we see patients in the emergency department with acute kidney injury. Obstruction is another important cause of community-acquired acute kidney injury, and this can be in the setting of benign prostatic hypertrophy or stone disease. The inpatient setting, of course, is quite different. In the medical ICU, for example, acute tubular necrosis in the setting of sepsis and nephrotoxin administration. On the cardiac floor, we're concerned about things like contrast nephropathy, post-cardiac surgery, acute kidney injury, and the cardiorenal syndrome in patients who have decompensated acute heart failure. In the SICU, some of the dominant causes of acute kidney injury are rhabdomyolysis, sepsis, and postoperative acute tubular necrosis. Acute kidney injury internationally is quite different from these. In sub-Saharan Africa, malaria is a cause of severe cases of acute kidney injury. Probably the dominant cause of acute kidney injury in the world is from diarrhea, particularly in children. In the tropics, leptospirosis is a consideration, so it's something to consider in the traveler who comes in with acute kidney injury. And other causes worldwide, post-streptococcal glomerulonephritis or post-infectious GN, and of course, crush syndromes in the setting of trauma. So let's go back to our patient, the 64-year-old with hypertension, diabetes, osteoarthritis, and BPH, who's in the emergency department with nausea and vomiting. Again, the medications included ACE inhibitor, an NSAID, and metformin. An exam showed a blood pressure of 100/60, a heart rate of 104, respirations of 16, and a really non-localizing exam. And the renal function tests were quite abnormal with a BUN of 84, serum creatinine of 3.2, hyperkalemia of 5.6, and a bicarbonate level of 18. So what are the first steps? First, I think you ask yourself, is this acute kidney injury or is this chronic kidney disease? So if you have a baseline serum creatinine, that's a very simple way to make that distinction. If you don't have a serum creatinine, which is quite common, there's some clues that are non-specific, but that you can use to determine chronicity. The presence of long-standing anemia is quite characteristic of long-standing chronic kidney disease due to decreased EPO production, but of course can be seen in any patient with an acute illness. Small kidneys on renal ultrasound are really evidence of long-standing chronicity, so less than 8 centimeters. That's really a sign that the condition has been going on for some time. The radiologists sometimes report increased echogenicity, which can also be seen in chronic kidney disease, but is not specific to CKD. And of course, you can have CKD that's complicated by acute kidney injury. So the next step is to ask, how urgent is this? So some of the things, of course, that really raise the stakes are the presence of hyperkalemia, if the potassium is greater than 6, or if it's rising fast. If the patient's not making urine, so anuric acute kidney injury is a much bigger emergency than someone who's actually making urine. The prognosis of patients with oliguric acute kidney injury is markedly worse than patients who are not making urine. The finding of severe hypoxemic respiratory failure obviously raises the concern in someone who's presenting with acute kidney injury. And if there's any suspicion of an intoxication, so some of the intoxications to keep in mind as causes of acute kidney injury are methanol poisoning, ethylene glycol, sometimes salicylates, and lithium. And all of these can be indications for acute dialysis. Physical examination can be helpful. Pre-renal azotemia can be associated with signs of volume depletion, for example, orthostatic hypotension, tachycardia, decreased skin turgor. The hepatorenal syndrome can present with stigmata of liver disease, and cardiorenal failure, signs of heart failure. There are no reliable findings on exam for post-renal failure. Palpable bladder is quite uncommon. And keep in mind that a normal urine output does not rule out post-renal obstruction. And the reason, I like to tell the residents and fellows, the reason for this is just the mismatch between the GFR, the glomerular filtration rate, and what I'll call the UFR, or the urinary flow rate. So the GFR is usually expressed in mils per minute, 100 mils per minute. So that turns out to be 6,000 mils in an hour, whereas the urinary flow rate is typically about 100 mils per hour. So you can have a substantial loss in GFR. If the kidneys aren't concentrating the urine, there can still be urine output. So remember, normal urine output does not exclude the possibility of post-renal failure. Causes of intrinsic renal failure, acute tubular necrosis, physical exam findings are generally nonspecific. There can be signs of volume overload if it's present, more advanced uremic findings such as a flap or asterixis or uremic frost are relatively uncommon. Glomerulonephritis has variable clinical findings depending on the cause, arthritis or rash. Vasculitis can be associated with palpable purpura. Atherembolic disease, so acute kidney injury that's occurring in the setting of cardiac surgery or following contrast administration during cardiac catheterization. Physical exam findings to look out for there include livedo reticularis and blue toes. Acute interstitial nephritis, rash, fever, and eosinophilia is the triad that we're taught, but it's relatively rare. About 10% of cases of acute interstitial nephritis present with all three of these: rash, fever, and eosinophilia. The studies to obtain in the patient with acute kidney injury include the Chem7, of course, the BUN, creatinine, calcium and phosphorus levels, uric acid and CPK can be helpful, CBC with differential to look for eosinophilia. In most patients with unexplained acute kidney injury, a renal ultrasound or computed tomography of the abdomen is helpful to exclude the possibility of obstruction. The urinalysis can be helpful, and the urine sediment. So the findings on urine sediment to keep in mind: acute tubular necrosis is associated with muddy brown casts or tubular epithelial cells or granular casts. Cases of glomerulonephritis can present with red blood cell casts or dysmorphic red cells. Acute interstitial nephritis, typically the findings are white blood cell casts or pyuria. The fractional excretion of sodium is probably the most often ordered test in the patient with acute kidney injury, and it can be helpful. So the traditional teaching is that a low fractional excretion of sodium, or FeNA, of less than 1% is consistent with pre-renal azotemia, and a FeNA of greater than 1 or 2% is consistent with acute tubular necrosis. And that can be helpful in the majority of patients, but keep in mind there's several exceptions. So first of all, you can have non-pre-renal azotemia even though you have a low FeNA. So for example, patients with contrast nephropathy can have a low FeNA. Rhabdomyolysis, even with severe acute kidney injury and clear volume overload, can have a low FeNA, as can early obstruction, early sepsis, and acute glomerulonephritis. You can also have pre-renal azotemia with a high FeNA. So even though the patient's pre-renal, the FeNA can be high. Common causes for this are diuretic administration. So if someone is on furosemide, the FeNA can be difficult to interpret. Some people have advocated using the fractional excretion of urea. And then pre-existing CKD is an important and under-recognized cause of a false positive or false negative FeNA. So in CKD, the baseline fractional excretion of sodium is higher. So you can have a high FeNA above 1%, even though the patient is, for example, volume depleted. So let's go back to the case. The gentleman with hypertension, diabetes, OA, and BPH, who's presenting with nausea and vomiting, medications of ACE inhibitor, NSAIDs, metformin, relatively unrevealing exam, and laboratory data showing a pretty significant AKI or CKD. So just to go through how I would approach this, we'll look for baseline labs. So in this particular patient, the creatinine was 1.0 a couple months before admission. So this is clearly acute kidney injury, not chronic kidney disease. Let's risk stratify this patient. So how serious is this presentation? I think it's not an absolute emergency ICU, but it is urgent. He's got hyperkalemia. He's got quite a elevated BUN and creatinine. The immediate considerations that come to my mind are pre-renal azotemia. Remember, he's on both an NSAID and an ACE inhibitor and has been having some nausea and vomiting. And which came first in terms of the nausea and vomiting and the acute kidney injury? Is that the sequence of events, or is the patient uremic and therefore nauseated and vomiting? That's not clear. But so remember, the NSAIDs act on the afferent arteriole, ACE inhibitors on the efferent. So that combination can be really particularly dangerous for a setup for acute kidney injury. We're also concerned about obstruction, given his history of BPH. And remember to stop the metformin. So he's got a gap acidosis already, so the metformin has to be stopped. In terms of the therapeutics, you'd probably volume challenge this patient, stop the ACE inhibitor, the NSAIDs, further evaluate for the possibility of obstruction if the kidney injury doesn't improve, and of course get some labs such as the UA, the urine sediment, and the fractional excretion of sodium. This particular patient was one of my first cases in fellowship, and actually turned out to be a simple case of pre-renal azotemia. So even with Pre-renal azotemia, the BUN and creatinine, as you've probably seen in your practice, can be quite elevated, and particularly in these patients who are on ACE inhibitors and NSAIDs. One of the things that we've recognized recently is that there's a long-term risk of acute kidney injury. So epidemiologic studies have suggested that up to 10% of patients with severe acute kidney injury requiring dialysis, even if it resolves, and patients are off dialysis acutely, if you follow them out for 10 years, about 10% of them will actually require dialysis in the future. So there's concern that cases of acute kidney injury are really signifying something either about the patient or about the injury itself to the kidney that leads to structural abnormalities within the kidney that predispose to the development of chronic kidney disease. Okay, so in terms of other lab evaluation, what if this patient, did not have pre-renal azotemia and post-renal obstruction was ruled out, and we don't have any good explanation for acute tubular necrosis? For example, there was no sepsis, there was no recent surgery or nephrotoxin exposure or contrast administration. We don't have rhabdo or tumor lysis or an ingestion. Some of the labs that we get in those settings are complement levels, which can be depressed in patients with acute GN. Can also be seen in atherosclerotic disease, so low complements, and TTP-HUS. Patients who have sepsis and liver disease will frequently have low complements, so don't be confused about the possibility of acute GN in all cases of sepsis and liver disease. ANCA and anti-GBM can be helpful because here time is nephrons. ANA levels can be helpful for investigating lupus. The LDH and haptoglobin can point towards hemolysis or thrombotic microangiopathy, but many cases of acute kidney injury will require a biopsy. Quickly, some patterns of creatinine elevation. If there's a prompt return to baseline after 48 to 72 hours of fluid replacement, that's very telling for pre-renal azotemia. A rapid rise in serum creatinine of greater than 2 milligrams per deciliter per day can be seen with rhabdomyolysis. This is anecdotal, hasn't really been studied well, but we've noticed it, that rhabdo often associated with a really rapid rise in serum creatinine. If the serum creatinine increases within 24 hours of a contrast procedure, it usually peaks within 3 to 5 days and returns to baseline within a week. That's the typical pattern of creatinine elevation in contrast nephropathy. And remember that this is typically non-oliguric. Aminoglycoside antibiotics, the acute kidney injury associated with these agents can be delayed. So the rise in serum creatinine can take up to 5 days. And it can continue to rise even after the drugs are stopped and return to baseline over 2 to 3 weeks. This is both aminoglycoside-induced AKI and contrast nephropathy can be non-oliguric. I show this slide, this newly recognized cause of acute kidney injury with a question mark, just to introduce some of the recent findings in the contemporary nephrology literature. Brodsky and colleagues reported acute kidney injury in patients during warfarin therapy. So patients who had really elevated INRs rarely can have acute kidney injury. And it's thought that red blood cell casts can obstruct the tubular lumen and cause acute kidney injury. This was a small case series of 9 patients who had biopsies after they presented with a high INR and acute kidney injury. The patients with CKD may be particularly susceptible to acute kidney injury, particularly if they're excessively anticoagulated. The complications of acute kidney injury include volume overload, hyperkalemia, metabolic gap acidosis, which can be both gap and non-gap. So the gap acidosis from retained anions like phosphate, urate, and hippurate and sulfate. Non-gap acidosis from impaired distal proton excretion. There can be hypocalcemia, hyperphosphatemia, bleeding from uremic platelets, and pericarditis. And as I alluded to before, long-term complications of an episode of acute kidney injury include the increased risk of chronic kidney disease and end-stage renal disease. Prevention of AKI is important, avoiding nephrotoxins, maintaining adequate intravascular volume. N-acetylcysteine, there's a slim and rapidly worsening evidence base for contrast nephropathy, but clearly no harm associated with its administration. Furosemide, observational studies actually suggest harm in patients with acute tubular necrosis. Randomized controlled trials suggest no benefit, but of course clinically there's widespread use. Bicarbonate intravenous fluids, there's some evidence for its use in contrast nephropathy, and it's currently being studied in an 8,000 patient randomized controlled trial out of the VA. Treatment of acute kidney injury, pre-renal azotemia, we improve hemodynamics, relieve obstruction for post-renal. And for intrinsic causes, acute tubular necrosis, no proven therapy, specifically no evidence for dopamine. For AIN, withdrawal of the suspected drug, sometimes steroids. This is a controversial area. Acute GN, of course, depends on the type of glomerulonephritis. And scleroderma renal crisis, remember, even in the setting of acute kidney injury, rising creatinine, ACE inhibitors are still indicated. Renal replacement therapy, remember AEIOU for indications for dialysis. So A is acidosis, E, electrolyte abnormalities like hyperkalemia, I, ingestions, but not digoxin. Digoxin is not cleared. Volume overload, and then uremia. So advanced CKD or AKI can lead to pericarditis and encephalopathy. So just a couple of take-home points. Acute kidney injury is common, often deadly, divided up into pre-renal causes, post-renal causes, and intrinsic renal causes of AKI. Indications for dialysis are AEIOU. Keep in mind some of the patterns of creatinine elevation that can point towards specific diagnoses, for example, in pre-renal azotemia, contrast nephropathy, and then rhabdo and aminoglycoside antibiotics. And beware the common exceptions to the fractional excretion of sodium. So let me go over two cases. Case one, a 66-year-old previously healthy man admitted to the hospital for crushing substernal chest pain. On exam, his blood pressure was 126/78, pulse of 102, respirations of 20. His EKG showed ST elevation in 2, 3, and F. He's treated with aspirin, unfractionated heparin, metoprolol, nitroglycerin, and captopril, and then taken to the cardiac cath lab, where he undergoes successful PCI of an acutely occluded RCA. During the procedure, the blood pressure was 120/70, and he remained hemodynamically stable thereafter. Serum creatinine concentration was 0.7 on admission and rose to 1.4 on hospital day 3 when captopril was discontinued. The creatinine continued to rise and was 7.8 on hospital day 9 when hemodialysis was initiated. The skin exam was notable for livedo reticularis. So this is a case of atherembolic disease or cholesterol emboli. The question is, the renal vessels most likely to be involved in the pathophysiology of his acute kidney injury? And the answer here is A, the afferent arterioles. So the cholesterol emboli actually lodge within the afferent arterioles and cause an inflammatory reaction. Case 2, a 75-year-old man is admitted to the hospital for severe diarrhea for the past 4 days. Past medical history is notable for hypertension and osteoarthritis. Medications were lisinopril 40, ibuprofen 800 TID, and metoprolol 50 Q-day. The exam is notable for a blood pressure of 100/60, pulse of 120, and decreased skin turgor. Labs show a creatinine of 3.6, a potassium of 5.8, and a fractional excretion of sodium of 0.4%. So in addition to pre-renal azotemia, the following causes of AKI can be associated with a fractional excretion of sodium below 1%. So this was the point I was trying to make about the common exceptions to the low FeNA. So RPGN, or rapidly progressive GN, can definitely be seen with low FeNA, as can rhabdomyolysis, as can contrast nephropathy. So the answer is E, all of the above, A, B, and C.